I'm happy to invite our first speaker, Dr. Sangeet Mittal, who would be speaking to us on managing dark side of clear vision, RD after cataract surgery. Dr. Sangeet is a very senior vitreoretina consultant from Thin Eye Hospital, Jalandhar.
Thank you. Good afternoon, everyone. So I'll be speaking on the darker side of clear vision, which is retinal detachment after complicated cataract surgery. Can I have, yeah, thank you. So in my talk, this is stuck. So in my talk, all the things that I'm going to present are, you can say, imaginary and fictional, and the views expressed are mine only, and they're not meant to hurt anybody. And the goal is to have a happy and a satisfied patient. So cataract surgery and retinal detachment, the risk of RD increases after cataract surgery, which is 1%, which is more in intracapsular procedures, and if the capsular integrity is lost, more if there is loss of vitreous loss is there, it increases to 8%. And especially in high-risk cases like myopia or symptomatic patients, it is even more. And it is also seen after YAG capsulotomy we do for posterior capsular opacification. The management of retinal detachment starts even before the cataract surgery starts. And we have to prevent actually not to reach that stage. And a meticulous fundus examination before the patient is taken up for cataract surgery is mandatory. And if there is any high risk, if there are any lesions, especially in high risk cases, they need to be treated properly by either by laser or by cryo. And then there are several intraoperative steps that every cataract surgeon should take while operating, because we have, the first thing is to maintain the visualization. Because poor visualization of retina is key, proper visualization is key to diagnosis and management of many retinal diseases post-operatively. And if you have something like this, it is almost impossible to see the retina post-operatively. So we have to take care that we don't land up in these situations. We have to preserve the corneal endothelium. We have to suture if the corneal incision is large. And we have to make an adequately sized anterior capsulotomy. Proper cleaning of capsular bag has to be done. And the lenses that we use should be compatible with the retinal surgeries. And we have to take steps to minimize the happening of PCO by proper cleaning of the capsular bag and by using square edge IOLs. And another thing is that is important is we should choose compatible IOLs. So what happens is, like in this video you see there was a silicone IOL which was used. And when we use silicone oil in these type of patients, it commonly sticks to the posterior surface of the lens. And then it is very difficult to remove it properly, and the optics is compromised. And again, you see in this type of lenses, which are the iris supported lenses, during a simple FGE procedure, the lens tilted and stood up, and it was difficult to do the surgery. But just by proper use of viscoelastic, we were able to maintain the lens in position. And now you see that the lens is stable even after doing a fluid air exchange. So these things have to be kept in mind when we choose the IOLs. And again, the IOLs with the, and then another thing is, like, if you have a PCR, you should properly manage it. You should recognize it early. Just don't ignore it. You can recognize it by when there is an increase in AC depth, there's loss of rotation, or there is a resistance to phaco. And you don't, what happens is, don't pull out of the eye immediately. When you see that there is a posterior capsular rent happening, just stay there, inject some viscoelastic from the side port, and then remove the main phaco handpiece out. Do a proper vitrectomy and put a proper IOL either in the bag or in the sulcus, whichever, depends upon the capsular integrity, what is there. Next step is to manage the lens fragments which have gone below. So posterior chamber nucleus fragments must be raised into the anterior chamber. But if the lens fragment has crossed below the posterior capsule and has descended into the posterior segment, they should be left in place for later removal with a full 3-port pars plana vitrectomy later on. And the one message that I would like to give is, just don't fish. Just focus on safe management of the anterior vitreous. Consider lens implantation if you could. Manage the wound and don't fish. And you see what happens if you fish. In this one particular patient, the nucleus has fallen. The surgeon tried to fish, and he created a large break right in the center of the macula, leading the patient to bad vision for lifetime. So in this patient, again, we had removed the nucleus. We used a phacophragmatome. We did vitrectomy. We put in oil. So oil was necessary because the break, we had to laser the break post-operatively, immediate post-operative period, and then we closed the case. Remember, lens material itself cannot damage the retina unless it is manipulated by a surgeon, and attempts to raise a drop nucleus into anterior chamber for removal creates unsafe vitreoretinal traction. Now coming to the last part, that is proper management. The first thing we have to do is we have to take care is optimize the cataract surgery. If I ask any retinal surgeon in the world, he will say the most difficult cases to treat are the ones with badly managed cataract surgery. And you see the various problems we face. There is a lot of hypotony. There's difficulty in insertion of the infusion cannula. And once, even if you get the insertion, it goes into the suprachoroidal space. You have to make sure that the cannula now is in the vitreous cavity, and then only you have to start the infusion. And here you see when we started the infusion, the incision was leaking. There was vitreous still in the wound. And we have to take care of this, remove the vitreous, remove the remaining lens matter, put in an lens, and then we have to push further for the vitreous surgery. And another case, you see the lens that has been used is totally improper, not for the size of the eye that is being used. The lens, while we are trying to manage the RD, the lens is moving. And in this case, if we do a FGE, the lens will come into the anterior chamber and cause problems later on. So we had to optimize this lens. We have to bury the optics below the anterior capsule, and then proceed for the vitrectomy. So now again, if you have not managed the anterior chamber well, then you see the IOL is now stable even after doing fluid air exchange. And then you do cryo and put in silicone oil in these cases. Now coming to the management of the retained lens matter which is there. So sometimes you will see that the lens matter is there and there is the retinal detachment. The point here I would like to make is, do you have to complete the vitrectomy before you try to attempt the removal of the lens in these cases? Because if you try to remove the lens, you try to cut the lens, or you try to fragment the lens, in the presence of vitreous, the vitreous may get entangled, the retina may be pulled, and you may be causing number of iatrogenic breaks. So first take care of the vitreous, and then you take care of the lens, and then if you have to complete your vitrectomy, complete the vitrectomy and proceed with the management of retinal detachment later on. So here now the lens matter is taken care of, the residual vitreous which is now remaining in the periphery is taken care of, and the fluid air exchange is being done. So in the last, there is management of dislocated IOLs which may be present with the retinal detachment. So this was a patient who had a dislocated 3-piece lens with a retinal detachment, and this 3-piece lens was fixated first. A scleral fixation was done. The flaps were created, and the sclerotomies were done, and the haptics were brought out and buried into the scleral pockets. And once this lens is stabilized, you can in fact, if you have a proper capsule, you can put it on the anterior capsule, and then you proceed with the management of the retinal detachment here. Because the patient had PVR, we did primary ILM peeling also, and then we did a fluid air exchange, and laser and silicone oil is again used in this patient. And this is another IOL. Sometimes this IOLs, you can't be able to fixate them. You see one of the haptic is broken in this IOL. This IOL needs to be removed. So what you can do is you can put PFCL to stabilize the retina, and then make a corneoscleral tunnel, bring out the lens and put in another lens, and then proceed with the cataract surgery. Then proceed with the retinal detachment surgery. So here the lens is being brought up and it is being removed, and another lens is being, because the capsule is adequate, so the lens can be put in the sulcus here. The lens is put, and further the retinal detachment is managed. I'm doing a primary ILM peel in this patient also, and now you see fluid air exchange being done. The break was treated, and oil was used as a uh, tamponade. So I think the time is over. So in conclusion, I'll say there are three types of cataract surgeons. The first is cataract surgeons with good VR knowledge who will do a proper pre-op and intra-op and post-op thing. And the cataract surgeons who know that there is something called retina and posterior segment will have some kind of retina surgeon working with them. And the last one is the phacologist who just aim to put lens and forget about anything else. And this is one example. I just thought that I was doing this I just thought this is a dislocated lens, but you see there was a whole part of the lens as part of the optic and one complete haptic which was missing and which has to be removed. So I hope we don't create such mistakes. Thank you.
Thank you very much. I think we can take some questions, but to begin with, one of the most challenging parts of this surgery is to maintain visualization.
Yeah.
You know, air bubbles can come into the anterior
Yes.
chamber, and I think I noticed you had a few bubbles in one of your
Yes. Yes.
cases. And also the frosting of the intraocular
Intraocular
lens. Do you have
lenses.
any tips for us that
I think the use of viscoelastic is one thing that you should keep in mind. If you have this recurrent problem of the air bubble coming into the anterior chamber, you can use viscoelastic so that the air remains behind. And also if you have frosting behind the lens, again viscoelastic, you can coat the posterior surface of the lens with the viscoelastic, you won't get it. But again, what I'll say is if there is a silicone lens, even if you use the viscoelastic, it won't stay there. So it's better to avoid these type of lenses which are not compatible with retinal surgery.
Any questions from the audience?
Sir, I have one query. Most of the time in these referred cases, the tunnel is pretty bad. They were already put some 3-4 sutures. So the minute you put it, your infusion becomes a washing machine, and the IOL starts floating around and hitting everything. So do you like to make a separate tunnel, superiorly close this properly, or do you just proceed with the same thing, or how do you do that?
I think it is situational, depends upon situation to situation. If you are able to repair the older tunnel which has already been made, I think that will be the best procedure. But if not, if you still think that there is a problem, then you can shift to another tunnel. So I had done one case in which what we did was like there was a clear corneal incision which had been done for cataract surgery, and there was a problem, and we can't do this. We created a scleral corneal tunnel just below that in the different plane, and we did the surgery. So it's I think all situational, depending upon the case.
I think another important thing is that whenever you are having a complication during cataract surgery, it's very important to close all the sections.
Yeah.
Especially when you are anticipating that there is going to be a subsequent VR surgery. I've often seen the patients being referred where they feel that the side ports really don't need to be, sutured.
Yeah.
But I feel that if you are using a tamponade, you'll be asking the patient to lie prone. And even during the surgery, sometimes you really have to spend time to close those sections before you can go ahead with the VR surgery.
I think when you are doing these type of cases, the most of the time is spent on optimizing the cataract surgery that has been done earlier.
Exactly.
You spend less time on retinal detachment repair, but mostly on the cataract surgery part.
Once nucleus has dropped or IOL has dropped,
Yes, sir.
do you prefer operating at the same time, means in operation theatre, or you prefer to wait and case to be referred?
So if you have a capable VR surgeon then do it. If you can do it, it's I think there is no harm in doing it. But the only problem is like nowadays most of the cataract surgery is being done in under topical anesthesia, whereas the vitreous surgery requires a local anesthesia, at least local anesthesia. So if the local anesthesia is possible and you can take up the patient, there is no harm in taking it up the same day. There is no harm. In fact, if you have delayed it, then you have to delay it for some time at least for the anterior segment inflammation to settle down, for the cornea to clear up, and then take up the patient for VR surgery.
And with how much minimum of training you can create a practical retina surgeon capable of removing dropped IOL and dropped nucleus?
Pardon,
Means
sir?
medical colleges mushrooming all over, means every district, one medical college. There is acute shortage of retina surgeons.
Yes, sir. So I think there is no harm. There is no harm in actually if in waiting also, but I won't advise that you should fish out the lens fragments if they have fallen. You try to bring them out on the same day. If you don't have access to a VR surgeon, I think it's best to close the case. Just as Dr. Manisha said, just properly manage the anterior vitreous, put in the lens if it is possible, then seal all the incisions properly, and then send it to a VR surgeon maybe a few days later, rather than fishing out the fragments on your own. That will be catastrophic.
I think just to add to what Dr. Sangeet has said, I think what he was basically meaning that what is the minimum training you need
Yeah,
for
okay.
taking out the nucleus. I think we have to be very clear on this, that there's nothing like that, okay, I'll go in and just take out the nucleus and come out. Either you are a VR surgeon where you are trained for everything, or you're not a VR surgeon. So once you go inside the vitreous cavity, you are not sure whether you land up with other complications like a retinal detachment or a retinal break. So you have to be completely trained. It cannot be a limited training just to be removing the nucleus.
Sir, I noticed you did the ILM peeling in that detached retina patient. So do you advise peeling regularly?
Not regularly, but those cases were PVR cases. Actually, they already had onset PVR. For PVR, I generally prefer to do a ILM peeling in the primary surgery itself.
Under air or under PFCL?
You can do under PSL, whatever is comfortable to you. In these cases, I didn't use any tamponade. I just peeled.
Thank you.
Thank you.
So